اهلا وسهلا دكتور حسين. هيقدم لنا Jardiance for chronic kidney disease now approved.
I would like to thank my dear Professor Dr. Inas Shaltut for her kind invitation to be with you today. We'll speak about the Jardiance for CKD patients now approved. As you know that CKD represents an enormous healthcare burden affecting more than 840 million people all around the globe. This is not the only issue. It's expected by 2026 that the prevalence will be increased by 16%, and the cost will be increased by about 23%. And by 26, the cases and patients' needs for renal replacement therapy, which means dialysis and kidney transplantation, may reach up to 24%. As we know that, we have known that the terminology of cardiorenal metabolic systems are interconnected. The heart is the most metabolically demanding organ. The kidneys regulate glucose and volume homeostasis, while the liver, pancreas, and the adipose tissue are essential for energy metabolism and whole body homeostasis. As you can see, the thing which is astonishing in this diagram, that most of people think that the diabetic patient's prevalence is higher than, or represent the second higher prevalence of disease all over the world. It is astonishing that CKD represents more than diabetic patients. As we can see, total type 2 diabetes, about 378 million, total CKD patients reaching 700 millions, so that it's much, nearly double of the diabetic patients. About 50% of type 2 diabetes have CKD. The heart failure patient, 60 millions, they're interconnected. 30% of them have diabetes mellitus, and 1/3, 2/3 have heart CKD. As you can see, heart failure is either with reduced ejection fraction or preserved ejection fraction are higher in CKD patients, and heart failure itself causes renal deterioration functions. And when we have GFR below 30, here the risk factors regarding cardiovascular disease are multiplied by more than 3 times. And as you can see, the most fear of patients in CKD patient that they will reach end-stage kidney disease and dialysis. This is not the truth. Most of the patients may die in CKD patients because of cardiovascular disease before reaching dialysis in these situations. This is the Jardiance or the empagliflozin process all over these metabolic arms. As you can see, it was approved first as a treatment for type 2 diabetes mellitus. Then came the EMPA-REG outcome study that showed that there is a cardiovascular and kidney benefits in people with type 2 diabetes mellitus and cardiovascular disease. Then came the EMPEROR study, either the preserved part or with preserved ejection fraction or reduced ejection fraction. They have shown that cardiovascular benefits in people with heart failure independent, either they have diabetes or without diabetes. And then came the EMPA kidney, which have shown that cardiovascular and kidney benefits in people with CKD, either with or without diabetes mellitus, so that these drugs have either other factors in these metabolic arms to play. There are several risk factors for CKD patients, and we have a lot of symptoms and signs for CKD patients. The thing which is very, very important, CKD may not be identified until it reaches advanced stages. That the process became irreversible. Up to stage 3, there may be no symptoms. Symptoms start to be obvious when the GFR below 30, which means stage 3, stage 4, and when it became below 15 in stage 5. So that before that, there are no symptoms or signs in most of CKD patients, so that they are a silent killer. As you can see, CKD is a high unmet public health need. 10% of the population have CKD, about 850 million population. It is a very important issue and burden for hospitalization, such as type 2 diabetes mellitus, heart failure, and cardiovascular disease. Regarding the cost may reach per person in the year up to $100,000. Previously, it was in the rank 16th place regarding the mortality. As you can see, in 2016, it was in the 16th place after diabetes mellitus regarding the mortality, and it's expected to be in 240 in the 50 space, so that we are dealing with a very high burden. The problem in this situation that most of cardiovascular diseases, hypertension, diabetes, 95% have CKD, which is undiagnosed, a very great burden. The CKD prevalence for general population, 10%. CKD prevalence with type 2 diabetes, 40%. The awareness in the population, in general population, only 6% know that they have CKD. And in high-risk group, only 10%, so that we have a great problem. The IMPACT kidney study have studied the effect of the empagliflozin, the Jardiance, in CKD patients with several criteria. It have taken North America, USA and Canada, Europe, UK, Germany and Italy, and Asia, China, Japan and Malaysia, so that we have 8 participating countries. They have 2 arms, this trial. Jardiance are taking 10 milligrams per day plus standard of care. The other arm is placebo once daily, the standard of care. What is the final outcomes? They have put that we have primary outcome. The primary outcome, either kidney disease progression, which means sustained reduction of the GFR more than 40%, sustained GFR below 10 milliliter per minute. Either reaching end stage kidney disease, or which means dialysis and renal transplantation and renal death. There is also cardiovascular outcomes. The key secondary outcomes, all-cause hospitalization, first occurrence hospitalization for heart failure and cardiovascular death, all-cause mortality. The inclusion criteria for this study is very, very important. It has taken persons more than 18 years, evidence of stable CKD and more may be progressive, GFR more than 450 to 90, with albumin-creatinine ratio more than 200, or GFR more than 20 to 45 milliliter per minute, receiving only on one item or one drug regarding the RAS blockers. They have not receiving previously SGL2 or combined SGL2 1 and 2 inhibitors. The exclusion criteria, these usually, they are not receiving the drugs. They are only receiving dual therapy, are contraindicated, no IV immunotherapy, and if steroids, not more than 450 milligrams per day. Maintenance dialysis patients, transplant patients are, of course, excluded. Polycystic kidney disease is excluded. Type 1 diabetes is excluded. Regarding the credence study, the ganagliflozin, it received the patient with GFR more than 30 to 90. The DAPA, 25 to 75. Here, it became towards a lower level, 20 to 45 milliliter per minute. What about the outcomes? There is reduction in the relative risk ratio by 28% for kidney progression or cardiovascular death, and by 14% for recurrent or cause hospitalization. This is the only study that have proven that this drug have reduced the rate of hospitalization rather than DAPA-CKD, which didn't address this issue. So that the consistent benefit for these drugs in CKD patients with and without type 2 diabetes mellitus, GFR from 20 to 90 milliliter per minute, with or without prior cardiovascular disease, with or without background use of RAS blockers. The effect of Jardiance treatment with respect to the primary outcome was generally consistent across pre-specified subgroups. The benefits of Jardiance treatment were consistent among patients with or without diabetes mellitus, and regardless of the GFR at randomization. Of course, here, more benefits we have gained in the patient with higher urinary albumin-creatinine ratio. The effective treatment of CKD, we have indirect to prevent the progression and direct issue. This is one of the few drugs that have prevented progression of CKD by direct action through slowing of the GFR and reduction of albuminuria. Of course, it have made restoration of tubular glomerular feedback mechanism. And this diagram is very important. SGL2 inhibition reduced glomerular pressure by afferent vasoconstriction, reduction of neural hyperfiltration, and stabilization of the estimated GFR. Reduction of neurohormonal improvement by reduction of intrarenal RAS activity, reduction of central nervous system activity, and of course, reduced blood pressure. Reduction of inflammation and fibrosis by reduction of inflammatory markers, reduction of fibrotic markers with reduction of tubular glomerular injury and albuminuria. Reduction of renal work and hypoxia with reduction of solute transport and oxygen demand with reduction of renal ischemic injury and increase of hemoglobin.
Okay, 2 minutes.
We'll speak about the holistic approach for diabetes mellitus and CKD, including guidelines. Lifestyle, healthy diet, physical activity, cessation of smoking, weight management. First line therapy for diabetic patient, SGL2 plus metformin. Second line therapy, GLP-1 receptor antagonist, and non-steroidal such as MRAs such as finerenone. And if still blood glucose is uncontrolled, I will search for other glucose lowering agents such as GLP-1 receptor agonist. For hypertension, RAS inhibitor may be added maximum dose. If not working, we can add calcium channel blockers and, of course, diuretics, and steroidal MRA in resistant cases. For statin and for lipid control profile, if we can use moderate or high intensity dose of statin, antiplatelet agents, antidiabetic PCSK9 inhibitors, or icosapent for triglycerides levels. Here are the guidelines for this story. They have found that
Last slide.
as you can see, all guidelines, the ADA, ACD guidelines, guidelines, shown that SGLT2 inhibitors across cardiovascular and metabolic spectrum is very effective, and even the European Society of Hypertension, International Society of Hypertension, and European Renal Association. So that here are the guidelines of KDIGO 2024. It is recommended for CKD and type 2 diabetes mellitus if we have GFR more than 20, CKD with heart failure with or without albuminuria. It is recommended if GFR more than 20. For CKD patients, it can be used above 20 if you have albumin-calcium ratio more than 20, grade 1A. And here is the very important issue. If we have, in this situation, albuminuria less than 20 milligram, from 20 to 45, here it is grade 2B. So that they are the new hero in the realm of nephrology. We have found at the end of this tunnel a light, fire and forget paradigm for this drug, and protect your kidneys and save your heart, and thank you.
Thank you, Dr. Hussein, for this elegant presentation as usual.